We start.
Okay.
Okay. Good night. Good night. This is the first reaction with Jess Fedorovics, professor of mood disorder and mood disorder, anxiety disorder, and bipolar disorder of Iowa University.
Yes, University of Iowa.
Yes. Jess, what did you think of correlation between the bipolar disorder and the cardiovascular disease?
Yeah, so there's a strong link between bipolar disorder and cardiovascular disease, and this has been seen consistently across a number of studies. In aggregate, we see about twice the risk of cardiovascular mortality in those with bipolar disorder than we would expect based on age and gender.
Okay, and you think there is a correlation with the sympathetic nervous system and the bipolar disorder?
Well, most recently we've been looking at that with anxiety and its treatment, and we have seen an increase in amplitude with stress tasks, increased amplitude but not frequency of sympathetic nervous activity with stress tasks. And what's interesting is that it's even anticipatory, so it begins even before the stress task begins.
Good. And what do you study stress tests in Iowa University?
Yes, so there's a variety of tests that can be used. We use a variety of challenges. One other challenge that we use is the cold water pressure test.
Good. And another question for us is very important, is inflammatory and bipolar disorder.
Yeah, so there's a pretty strong link between increased levels of a variety of pro-inflammatory cytokines in those with bipolar disorder. This has been seen across multiple studies. In some of our research, we've seen that there may be state-related changes here, such that those with abnormal mood states, such as mania or depression, may have even higher levels than those that have normal mood or euthymia.
Good. And what the better treatment for you in the depressive phase in patient with bipolar disorder?
What treatments?
Yeah.
Yeah, I mean, so traditional mood stabilizers like lithium is a key first-line treatment for depression and bipolar disorder. We also use other treatments such as quetiapine, lorazepam. There's evidence for divalproex being effective for depression as well, acutely.
And your experience with lorazepam, what is now? Is good?
I haven't done any research with lorazepam. Clinically, I do use it for bipolar depression.
Yeah.
And I have had people respond to it.
Yeah. You think is a response with lorazepam in patients with depressive disorder in patients with a bipolar disorder?
I've generally used it in bipolar depression.
Yeah. Okay. And what do you think or your experience in patients with bipolar disorder that have diabetes?
Yeah, so diabetes can be comorbid with bipolar disorder, and those with bipolar disorder have a higher risk of it. Certainly want to be cautious with using medications that might worsen weight gain or diabetes.
Yeah, with there is a treatment with valproate is increment insulin resistance and
Yes.
can be a risk factor of diabetes in the future.
That's right. That's right. As well as some second generation antipsychotics have shown increased risk of incident diabetes.
Yeah. And you don't use in patients with diabetes. What is the top treatment? The beautiful.
I think of lithium as being first line for bipolar disorder in general, and it's certainly a good choice for folks with diabetes. Although keep in mind that both lithium and diabetes may be risk factors for kidney disease, so you want to make sure that you closely monitor renal function during treatment.
Okay, thank you. Do you have something experience in patients with bipolar disorder and sleep disorder?
So certainly obesity is comorbid to bipolar disorder. Obesity is a risk factor for sleep disorder. Sleep disruption is characteristic of both mania and depression. In fact, it's a diagnostic criteria for each. But those with bipolar disorder may have sleep disruptions even outside of mood episodes. And so even during periods of euthymia, we may see sleep disturbances with bipolar disorder.
Okay. And you think is necessary in a patient with with the patient with bipolar disorder in the phase with depressive in the phase of depressive give an antidepressant in patient with bipolar disorder? Not is correct for you?
You cut out during that question. Could you repeat the question, please?
Give a patient an antidepressant with bipolar disorder when this patient is an period of depressive. When is it depressive?
I think that the International Society for Bipolar Disorders put together a task force that published guidelines on the use of antidepressants with bipolar disorder. And I think in general that these guidelines are quite good. So situations where it might be reasonable to use antidepressants for bipolar would include when the person has a history of response to antidepressants and is not in mood state. Another
Sorry, yes,
your hypomania.
Yes, sorry. Can you repeat it, please? There is a no good connection. Excuse me. Can you repeat it, please? There is a no good connection.
Yeah, we've been having some issues with the connection. So, as far as the use of antidepressants in bipolar disorders goes, I think the International Society for Bipolar Disorders Task Force put together some really useful principles for this. Situations where it would be reasonable would be someone that doesn't have a history of mania or hypomania with antidepressants, has previously responded to antidepressants, a mood stabilizer is being used concurrently.
Yes.
Certainly, anecdotally, I have had some patients that have a history of response and where taking them off of antidepressants caused them to do worse. And so I do have some outpatients that are receiving traditional antidepressants for bipolar depression, but I don't think of them as my first line.
Okay, thanks. And other question for us is important. In Iowa, I know there is psychotherapy very important. This psychotherapy is ACT therapy. Do you utilize ACT therapy in patients with bipolar disorder?
Yes, we have. And so our Mood Disorder Center has set up several ACT groups, and I've been involved in some ACT research studies as well. And so I think the principles of it can be useful for a variety of diagnoses, and bipolar disorder is not an exception to that.
And you have a most responsive with ACT therapy in bipolar disorder, in a depressive disorder, or in anxiety disorder?
In depression or mania, you said?
Yeah.
So certainly, I think the principles of ACT can be useful for those suffering from depression and bipolar disorder.
Okay. You can illustrate.
It hasn't been as well studied there, but I mean, it's designed to be transdiagnostic.
Okay.
So I think of it as an evidence-based principle.
I know when I come in Iowa with you,
Yes.
I remember that I see the heart therapy determine the pressure of blood less in patients with bipolar in anxiety disorder. Remember?
The studies we've been doing with ACT have involved those with high anxiety, and those have been mixed anxiety disorder samples. And we're currently analyzing the final data for that.
Yeah, I see the patients with high pressure with the heart therapy. Then your pressure is of blood is normal.
I don't recall us seeing changes with blood pressure with the treatment, although we did look at it, and we are in the process of analyzing that. So hopefully we'll have results out within the next year.
Okay. And other questions for us important is your work with Gary Pierce
Yes.
with the sympathetic nervous system.
Yes. So my main project with Dr. Pierce is wrapping up in the next few months, and that's some of the data that we're hoping to publish in the coming year. So Dr. Pierce has a postdoc, Dr. Holwerda, who has been doing direct recordings of muscle sympathetic nerve activity. And he did publish a paper with us looking at that in anxiety, which had some interesting results. And I mentioned those earlier. So essentially we saw increased amplitude, but not frequency of sympathetic nerve activity with the stressor, and even preceding the stressor in those with high anxiety.
You can explain you can explain it as some in your lab with function the sympathetic nervous system.
Yeah, so we can directly measure it in the peroneal nerve through muscle sympathetic nerve activity. We can also look at indirect measurements, such as you might acquire through heart rate variability.
Good. Yes. With the sympathetic nerve, with the peroneal nerve.
Yeah, that's our direct measurement. Yeah, and that's sort of, I think, the more innovative one that we're doing. And Dr. Holwerda has been the lead on those projects.
Okay. Yes, I left your work, and I very honored with explain with you a small interview. You are.
Well, thank you. It was fun to have you out here, and I appreciate your interest.
Thank you. We are honored to with this interview with you. Okay.
All right. Well, Thanks so much.
Bye bye, Jess.
All right, bye. Take care.
Good work.
All right.
Bye bye.